Welcome everybody, and thank you for joining us today. Next slide, please. Ambreen and I would like to continue to share with you our journey building equitable patient partnerships with EMPaCT. We'll bring you up to date on our journey and recap some of our key thinking. Then we want to look at how we identified some common goals. And finally, we're going to explore how we're building from the opportunities that we have. Let me start by introducing myself. So I'm Elise Maybe. I've been a patient mostly due to accidents, starting with a near fatal car accident in my early 20s and capping it off last year with a broken ankle. Along the way, my Dutch mother was diagnosed with dementia and I became a remote caregiver, having to learn as much as I could about the Dutch healthcare system and the language. All of that got me thinking about the healthcare system, and I became a patient partner in 2011. I started at my local hospital as the first of 2 patient advisors, and I went on to become involved in more than 10 research projects, my local health authority, council, and various policy groups, both for Ontario and for Canada. I'm also a co-founder of the Patient Advisors Network, or PAN, a community of practice for patient and caregiver partners across Canada. It was set up in the spirit of peer support and in an effort for us to learn from each other how to be effective patient partners. So one of my main areas of focus is patient engagement itself. I started thinking about patient partners, how they are and how they can be involved years ago when I first got involved with the Strategy for Patient-Oriented Research, or SPORE projects. I delivered some curriculum around patient engagement in research, both mine and of others like CIHR. And I've learned a lot, and I've thought a lot about the whole business of partnering. More recently, I've been involved in co-creating patient engagement frameworks or guidelines for various groups. And in all of this work, everyone has wrestled with how to find and recruit a wide diversity of patients and caregivers. So over to you, Ambreen.
Thank you so much, Elise, for sharing that with us. As for me, I'm currently a recipient of a Patient-Oriented Research Fellowship Award from the Canadian Institutes of Health Research. But my journey to this point is actually quite convoluted, taking me across the world and across all bands of the healthcare system. I've worked in clinical practice, providing care as a general surgeon. I have worked at the lab, culturing viruses for experimental gene therapy. I've held leadership positions across the healthcare industry, and I've been an entrepreneur. And while all of these experiences may seem quite disparate, the thread which ties them all together is the fact that I've been on a constant journey of trying to build a healthcare system which works better for all patients. And this is really the point at which I met Elise, understanding the idea and the phenomena as to why is our healthcare system so exclusionary, and why is it that we are unable to include certain patient voices in the redesign and restructuring of the healthcare system so that we can improve the healthcare system to kind of nurture the environment where everybody can reach their optimal health. I think the unique vantage point that I bring is really that, having occupied all these different stakeholder positions, I'm able to understand what makes each stakeholder tick. What are their priorities? What are the needs from their perspectives? What is the language that they speak? And which boundaries can be pushed within reasonable limits in terms of innovation and creativity without sounding absolutely outrageous? And this is where Elise and I, we met, and our journeys have intersected. And what was a brief discussion on patient engagement, patient partnerships, and building inclusive relationships has spiraled into this ecosystem of friendship and care and consideration, which is the foundation of building what we've put together.
Yeah, so I'm well aware that I'm like what they call the usual suspect, white, female, older, reasonably educated, and comfortably off. So I'm representative of the majority of patient partners, or at least that's what it seems like. And I'm frequently asked, how do we engage with others not like you? Good question. So I've thought about this a lot and had a number of discussions with various patient partners who have various profiles and backgrounds. Cracking this nut is central to moving patient partnerships to the next stage. And then I met Ambreen. You know what it's like when you meet somebody and you talk with them and it's like they read your mind? That was us. To say we are interested in the development of patient partnerships with diverse groups is way too tepid. It doesn't capture the commitment, the energy, the ideas that we spark off each other, or the easeful way that we work together, or the pleasure in our developing friendship. Considering we've only ever met virtually, we have managed to develop the trusted relationship of the sort that's needed to partner effectively. So it can be done virtually, and I can't tell you how optimistic that makes me, though I do miss hanging out over coffee. Most of us have many aspects to who we are. We can be gay, highly educated, and a newcomer to Canada, or we could be young, speak a language other than English more fluently, and face housing insecurity. Putting us into one bucket ignores other aspects of ourselves. And what unites us all is being human. Our Canadian population is very, very rich in diversity, and the tapestry of our society makes it really interesting, but it also makes it challenging, especially when it comes to like fairness and equity. This challenge exists in the delivery of healthcare services, in health research, in policy making, and especially in engaging patients and caregivers to work to improve all aspects of healthcare.
And this really brings us down to the point that Elise and I met on and have tried to think about and bring back to the drawing board. And the healthcare system and the structures which surround it, our social support systems, for example, have predominantly been conceptualized and designed from the lens of a white, able-bodied, cisgendered man. And if we are able to create a Venn diagram of sorts with all of these different categories, being white, being able-bodied, being cisgendered, and being a male, then the more parts of the chart that you can map onto, the odds that you will receive the care which suits your needs is higher. But if by chance intersecting social identities that one may have do not fit into any of these buckets, the odds that the healthcare system is not serving your needs are quite high. These pre-constructed parts of the healthcare system need to be redesigned. They need to be reconsidered. They need to be reshaped. And in order to do that, we need to bring in more voices. So really, we need to understand whose voices are missing in the first place. Why is it that our system is exclusionary? What will it take to become inclusionary? How can we become better at listening and learning from community, who are already the experts of their daily lives? And how do we co-build with them a community of practice which serves and prioritizes their needs and is responsive to their healthcare priorities?
This takes thinking differently about some of the challenges for patient partnership. And so I would like to focus on three in particular. Firstly, there's the language and culture of healthcare. Like all industries, it has its own unique culture. For example, I come from a high-tech culture where people shoot from the hip and state their considerable opinions, punctuated with the F word. Healthcare culture is very different. People take care to acknowledge each other and mostly refrain from profanity. And the language, especially the written language used, is way beyond the grade 6 to 8 level that is considered appropriate for communicating with the general public. Sometimes it's downright convoluted, highly specific academic or specialist language. Like any new country, patient partners need to learn the language and understand the culture or have very good translators. Space is both physical and emotional. Place and space are elements of power. The majority of meetings that we are invited to are within the healthcare organizations. And while this makes a lot of sense from many perspectives, there's free space and the professionals are already conveniently there and booking is really easy. It's not that easy for us as patient partners. These locations may be places where we have experienced trauma and loss. And hospitals are at best labyrinthian, and maps are not always in evidence. And the university settings are worse. You need a degree to get around. This is also a question of turf, and turf is power. Patient partners are usually just guests in the healthcare home. And then finally, there's practical considerations. Good intentions can trip up over practical considerations. In my experience, really knowledgeable patient engagement folks have learned to accommodate some of these considerations very well. They check in order to schedule at times convenient for patient partners. They ensure that meetings don't go on too long and exhaust people. They provide expenses to reduce hardship, and they ensure there's accommodation for accessibility and so on. So these practical considerations should not be sneezed at. I accompanied a wheelchair-using colleague to a meeting only to be stopped dead at a large French step at the front door of the building. Fortunately, the super had a handy ramp, and 15 minutes later, we were making the meeting. There are probably a lot more challenges that I haven't covered, but I think language and culture, place and space, and practical considerations are ones that merit particular attention. They embody power, and they include or exclude.
So our task really was to be able to think differently, and think differently not just about the three examples or the three categories that Elise just spoke about, but to think differently about how can we change the configuration of power in patient engagement and patient partnership. How can we flip it so that the community can decide who, how, and when do they want to engage, on what terms, and to what outcomes and what effect? And how can the community decide what an inclusive space would look like that they would like to be engaged and partnered in? And these were the assumptions that took us on this journey of identifying what are the common goals across different stakeholders and how can we begin to bridge them into opportunities. So Elise and I set off on a journey of formal and informal conversations, and we engaged with the patient and community stakeholders. These included patient partners, patient partner working groups, and community members. We engaged with internal stakeholders at Women's College Hospital, where I'm situated. That meant consulting with the leadership. It meant speaking to the Equity Advisory Committee, supporting scientists and collaborators. We also spoke to external stakeholders, such as funding agencies, community health centers, social workers, patient advisory panels, and health system decision makers. And for us in particular, that included the Canadian Partnership Against Cancer. This chart just describes briefly how we engaged across the different stakeholder groups across a period of 6 months from June to December 2020. But what I'd really like to show you is this chart. This chart describes how we spent our discovery phase of listening and learning from different members of the stakeholder community. What's important to see here, well, there are two things. One, that it's important to engage with all stakeholders. We cannot identify common goals unless we are speaking to everybody. The second part is that you prioritize your time based on what you want to learn. And for us, learning from the patient community was centerpiece. We prioritized the patient and community voice, and we spent most of our time listening and learning, building off relationships, and understanding how and what makes the system exclusionary and how can we make it more inclusive. What did we learn? Well, the patient community reminded us that participation is usually just by invitation. There is little control over who makes the decisions. Patients are invited by healthcare institutions. That means the number of patient partners that are invited are decided by institutions. How frequently and when the microphone is passed to a patient partner is also decided by institutions. And when patient voices are included in a narrative, they're usually considered anecdotes and are not given the value and privilege of knowledge. We also heard that stereotyping, judgment, and bias was prevalent. And this predominantly occurred through language and the use of power through language. What did the internal stakeholders tell us? They told us that there's usually short-term funding of projects. So projects are funded, they have a start point, they have an end point. Patient engagement is usually built into the fund of the project, but when the project ends, the patient engagement ends. Health equity is too abstract a thought to be able to build into tangible, everyday opportunities. There is, however, an eagerness to change processes for better outcomes. External stakeholders, such as funding bodies and decision makers, are increasingly legitimizing other forms of knowledge. There's a realization that communities need to be involved in the reshaping of the healthcare system, and they're willing to go the extra mile and fund innovative methods.
So all that learning uncovered key goals shared by all. Patients and community want to be involved in change. After all, it's our health system, it's our health, and it's our tax dollars in many cases. Other stakeholders would like to see us involved too. Healthcare is changing really rapidly right now with the onset of COVID and the need to plunge into virtual care. So we need all hands on deck to make sure that we make the changes that are fair and equitable for all. Internal stakeholders would like to see equity built into the processes. Well, so would patients and caregivers. And external stakeholders like research funders and policymakers want to be sure that they're not leaving people out and therefore making poor decisions. And everybody wants to see good processes for achieving equity and equitable outcomes spread and shared widely. Let's turn our attention now to how we can use the building blocks of opportunities to nurture an equity-focused community of people. If we look at the top layer of this diagram of this building block, of these building blocks, there are existing partnerships across all stakeholders that we all have that can be a great place to start. Many of your partners will recognize the need to both focus on equity and to hear from many different points of view. And there is more and more research about good and bad ways to engage patients and communities with toolkits and the like. And increasingly, the value of patient engagement is being understood. For example, service delivery impacts clinicians and their patients. Both parties should be involved in co-designing improvements so that the results benefit both. In research involving patients, helping to target the research to what really matters, targeting it to what matters to the people whom the research is supposed to serve. That's important. And there are resources, tools, people, money that have been designated by organizations and by funders to support both equity and engagement. So we have all of those things coming together.
When it comes to support, I think this is a whole webinar topic in itself. And there is a saying, it takes a village to raise a child, but actually it also takes a village to build a community. For those of you involved in patient engagement, you will recognize that most of the tasks are invisible, but they are key to the success of any patient engagement work. And these invisible tasks include in-kind support from your peers and colleagues at work who carve time off the side of their desk to support the work real time as it's happening. In terms of the support structures that we particularly had was a strong sounding board of scientists and members of community who have deep experience in this work. So we could go back with our ideas, have a chat with them, have our ideas challenged, carved, and reshaped to go back and through an iterative process. Also key to this was institutional support, leadership support from Women's College Hospital, where values and organizational commitment towards health equity are key. I think it's also important to say that we had several scientists supporting our work. These supporting scientists were a cushion, and they still are a cushion because we're building a plane while flying it. And then there are the many administrative tasks which often go unrecognized, but are perhaps, I think, some of the essential pieces of the jigsaw puzzle that are going to make this work. And in particular, I would like to, acknowledge and give a shout out to the legal, finance, and procurement team at Women's College Hospital. They have been back and forth with us over patient engagement contracts, be willing to reword the sentences, think of ways of simplifying the language, talking about different ways to compensate patient partners. We've had conversations about, can we do e-transfers through email? What are the assumptions? What are the limitations of that? And even with the procurement department recently, when we trying, and we're still going through this actually, trying to purchase tablets for some members of the community who are looking to engage with. So I think these are just a few examples of the invisible work that goes on, but this key support structure, this whole infrastructure of support, underlies the foundation of any good patient engagement strategy. And then, of course, is the funding. Everything needs money. And I'm fortunate to have a fellowship award from the Canadian Institute of Health Research that protects my time to do capacity building in equitable patient-oriented partnerships. And we've also recently received the Empower Award from the Ontario SPORE Support Unit. These developmental funds allow us to seed and grow an innovative way to engage patients. These funds allow us to compensate patient partners when they are engaged with us. They allow for us to train in different areas that are required. And they've even enabled us to purchase devices as and when needed for digital enablement. Our work now, as we look into the future, is to find ways to build a sustainable model of funding. And this too is something we're actively working on with support staff at Women's College Hospital.
Relationships. We start with the people we knew who had a variety of lived experiences that led them to be interested in health equity. And then we snowballed into community through direct relationships. We talked with people individually, getting to know them, listening to them, and asking them if they wanted to come with us to build a community. And we asked them what they need to enable them to join us in the community. Building relationships is baked into everything that we do, including our meetings. We learned that if we need the time to spend on relationships, we must take the time. Relationships trump the actual work of the meeting. We fleshed out how we want to work together and are continuing to work things out as we create the community. As Ambreen said, we're building the plane as we're flying it. A community is only as strong as the relationships of trust that bind it together. And so we brought all of the pieces together. And this is what EMPaCT is. We're in the process of building EMPaCT as a community to focus on health equity. Equity-Mobilizing Partnerships in Community, or EMPaCT, is a patient partnership model co-designed to center the voices of diverse community members and build capacity for equitable patient-oriented partnerships. As a community of diverse patient partners, EMPaCT aims to improve health outcomes and, in particular, health equity by consulting, assessing, and evaluating projects through the lens of their lived experience. It is an innovation which we hope will succeed, and it's a community learning as we go along. We'd like to share a short video with you that covers how we identified the pathways to change. So we'll take a few minutes to see the video.
What we learned from community and what we've taken back in terms of pathways to change is really that tangible opportunities need to be clearly defined. What happens then is there is transparency in the process, and there's accountability to the people who brought the project forward to community. This exercise removes it from becoming a tick box activity and instead builds trust and motivation to participate in these processes. This is a summary of our journey to date. From a coming together of minds and resources in June 2020 to March 2021, we have gone through an inception of the idea of EMPaCT, the growth of membership and support structures. We have been able to define a shape and scope to the EMPaCT project, although this shape and scope continues to be redefined as and however frequently we engage with community. We have received funding from OSU for the scale and spread of impact from EMPaCT. And we're looking forward to nurturing this innovation and growing and learning and scaling the impact across different communities.
So we'd like to sum up and leave you with a few key messages here. The first one, relationships rule. A community is based on relationships of trust. Secondly, engage stakeholders to identify goals and opportunities, and that's all the stakeholders. Co-build the processes with the community. Be willing to try things out, then undo and redo as the community decides on what works and what doesn't. Move quickly, be agile, and don't let things fester. This is an innovation. It requires an investment of time and thought and action, and it requires a willingness to change.
I would just like to end by acknowledging all the community members of EMPaCT and for joining us on this journey as we co-create a new way to build patient partnerships. In addition, I'd like to acknowledge the institute where I'm located and all the funding bodies that have supported this work, and the many team of supporters that have come together to form the foundations on which we can go forward. Thank you. Please feel free to contact Elise and I through these email addresses, and we look forward to taking any questions.
Thank you.
Great, thank you both so much for that very insightful presentation. We still have about 15 or so minutes to take any questions from the audience. So if you haven't yet submitted your question to the chat, you still have time to do so. We also asked a question earlier about what you are hoping to gain from the presentation and how it could potentially help you in any of your work. So we'll also go over some of the responses that we heard to that question. So our first response was, I wish to be an effective patient advocate, especially at my cancer clinic and hospital. I am meeting with the foundation after this to talk about my patient experience for the donors. Another insightful comment we heard was access to information or lack thereof is also a great power imbalance for patient partners. Opacity of information from organizations and lack of patient partners in paid staff roles are blockers to having patient partners be able to have real organizational impact through access to information, decision-making, staffing, and budgets. Do either of you have any comments on this?
Yeah, I'd like to jump in on that because I think that's an extremely important point, because information in itself is power. And so much of the information that we're given is given in language that is a bit opaque to start off with. And then furthermore, a lot of the papers and so on sit behind paywalls, which is not very helpful for patient partners. So there's a number of issues here. One is the cost, the paywall cost, and frankly, for me, the cost of printing out tons and tons of paper and then taking the time to read it. But I think we need to move to finding different ways to transmit information, not the classic ways. We need to start using things like infographics and more modern types of communications that people are used to consuming, videos and that sort of thing, animations. Complex information can be very well disseminated sometimes and better through animations, through infographics, through visuals, and so on. So I would really like to see us all push to see more and more of that, where the disciplines of marketing and communications are being adopted throughout the healthcare system. Thank you.
I think I'll add a couple more comments to that. I think the idea of compensating patient partners through honoraria sounds very nice in ideology, but there's a lot of institutional work that needs to be done to be able to actually move the paradigm in how we do that. And Elise and I have both worked with a lot of support from Women's College to kind of see the language in how we approach patient engagement. What do those introductory contracts look like? Why does it even need to be a contract where a patient partner needs to sign indemnity and liability? How does that language actually inhibit patient partnership processes? And how does that in itself create a structure as to who can come on board and who cannot? Another interesting thing that we've learned along this way is that there's a cap, so that when you reach around $500 of honoraria a year, then you need to switch to a contract model instead of just gift cards and posted out checks. That has a couple of assumptions. One, that a person is going to be able to download a form, be able to fill it out, be able to send it to you, and a lot of other complications that come with that. So I think there is the idea of patient partner compensation, but then there's work, real work to be done to be able to change how the system is currently structured. We are currently designed to have employees in hospitals, and patient partners are not employees. If they are brought on as employees, they're not. I think we need to have flexibility in how those terms and conditions are structured.
Great, thank you. Next question, could you expand a bit more about the ways that you engaged community groups in the early stages of your project?
So
Elise, do you want to take? Yep.
Yeah, I'll start out. So one of the things we did is we went to groups that we knew with people where we had relationships and talked to them about this idea and shared some of the sort of early ideas that we had and asked them if any of them wanted to become involved. So it was going to sort of groups that we already knew and also individuals that we already knew. So there were a lot of one-on-one conversations, small group conversations, a lot of iterations of conversations as we built relationships and explored ideas together. And that's really how we started, at least from my perspective. Yeah.
And I think if it wasn't our own direct relationships, it was, I think I need to backtrack a little bit by saying that patient engagement is something which neither Elise or I started in June 2020. This is something we've been doing for a long time in different capacities for several years. So some of these relationships were really deeply embedded and widespread. And then we could snowball from those relationships into further relationships within the community. So it was building off this infrastructure of networks and relationships and then growing that to expand further and deeper.
So regarding some of your earlier comments about the different risks associated with compensating patient partners and the different strategies that you can implement, we have some follow-up comments. So there's definitely a risk in compensating patient partners, but I think there's something to be said for patient engagement initiatives led by patient partners as staff, leading volunteer groups as opposed to patient satisfaction staff. I think that nuance and approach is important. Anything to add there?
Yeah, I guess I'll start with that a bit, or I'll try, if I understand it right. There's a lot of things that need to change. Patient engagement initially was borked onto existing institutional thinking forms, structures, and so on. But in some senses, we're a completely new type of category. And that is only just really being wrestled with, I feel anyway, more currently as people are starting to look for the compensation forms and so on, the different ways to compensate people. And then there is the wild card of some people can't afford to receive compensation because it jeopardizes their support. And so we really need to think about this differently. I don't think there's any slam dunk answers to any of it. I think it's an experiment, an exploration. There needs to be deep, open conversations. Some of the barriers to having those conversations are sort of the institutional mindset of this is the way it is, this is the way we deal with it, this is the way we deal with contractors, but patient partners are not exactly contractors. So it requires a willingness to think in terms of things differently. First of all, that patient partners are not something that has existed in the frameworks that were there traditionally, that were new, and therefore there may be needs to having new types of structures to support that, including compensation structures.
I think I just have one more comment to add to that. Is we need to be responsive and flexible, because unlike other employee contracts or engagements, the term should pretty much be defined in co-creation with the patient partner when they come on board. With an employer-employee relationship, there is that power dynamic inherent. But it really, for a successful patient partnership, the model needs to be much more fluid. And therefore, that means that flexibility and agility in terms of engagement needs to be there. And that requires push and shove from all sides, along with the flexibility to be able to find a solution that fits. I think otherwise we're just creating barriers in terms of who can participate and how they can be encouraged and motivated to participate in a change process.
Absolutely. And continuing with discussions about how we can make the process more inclusive and involve people. Another question, how do we push back against the resistance of making the system fully accessible? For example, for people with disabilities, people often state that it would take too long or that it would be too expensive of a process. For people whose first language isn't English or French, there's often the comment that translation or interpretation would be too costly. So how do we move past some of those barriers towards accessibility?
Wow.
I think, yeah.
Sorry,
Sorry, go for it.
But
no,
again, you know, there's a view that you only look at the cost side of things. So it's going to cost this in time, it's going to cost this in money. But there needs to be a cost benefit or a value equation here. What is the value of inclusion? What is the value of providing those barriers? It's not just the cost, it's also an investment, and it needs to be thought of as an investment to greater value, the greater value of having a variety of voices that can then make more robust services that can serve people who therefore are less of a drain on the healthcare system down the road, because they're dealt more as human beings and brought more into a sort of a preventative mode as opposed to a crisis mode. So that's just sort of a very high level view of it. I think the details start to get rangy. There's no question about that. But where there's a will, there's a way. Ambreen, do you want to add?
I don't think I have anything to add to what you said perfectly, Elise, except I think just that you prioritize the budget, right? It's even the household budget, you prioritize what you need to do at the end of the month. And it's the same with all other budgets. You prioritize what needs to be done. And if those levels of inclusivity are considered important enough, they will get priority in the budget. It's just about prioritization.
Great. Next question, how can I ensure that my role as a patient partner is meaningful and that I'm not simply there for tokenistic representation?
Oh, well, I'd love to jump in on this one. Yeah, I think we've all, you know, I've been doing this since 2011, and we've all discovered moments where we are the classic tick box, if you will. And I think for everybody, when I found myself in that situation, you know, I'm faced with, do I stomp off in anger? Do I grit my teeth and keep going? Do I try and fight internally to make myself more of a meaningful contributor? I don't think there's any easy answer to that. I think it depends. It depends on who you are, how long you've been doing this. It depends on the circumstance of your engagement. Is this engagement a place where you can actually have a learning moment with people? You know, and I don't think there's an easy answer to that. I think part of the sort of overall answer is that our partners who are on the other side of the partnership can do with, you know, training and support and all of those things so that they understand better how to engage with us in a more meaningful way. I also find that just over time, as you learn more about things, you identify places where you can actually step in and speak up. And I found myself in that position in some of the strangest places where I feel like I've just got a preponderance of these really big brains around me with, all kinds of expertise. But I'll make a comment or I'll highlight something that they've never thought of because they've spent their lives being very, very detailed in their knowledge and their understanding. So the overview is sometimes lost to them, and they need people like us who experience the system widely to go, well, now wait a minute, as a patient, this doesn't make sense, but if we tried that, could we try that? Or I've been working in this or that industry and we tried X, what about seeing if that would work in healthcare? And I think those are some of the things that we can bring to the table, even in spite of ourselves in some ways, where we can add meaningfully to conversation. I mean, you will from time to time meet diehard, people who are not going to shift and so on. And then it's really a decision over whether you stay or whether you don't, and what you do when you leave, if you do leave.
I think in terms of EMPaCT, one of the earliest things that we heard was we don't want to be tokenistically involved, right? So if we are at all involved, we need to know that we are contributing to change. And therefore, the whole idea of pathways to change came from that conversation. Research is a long cycle of change. So when patient partners are involved, the likelihood, or even us, the likelihood that we're going to see the impact of that change in society is way down the line. But if there's transparency about that pathway, and there is that kind of communication channel between everybody, right? So this is a research project. It's going to take 3 or 4 years for the research project to conclude, and then the research will go out. So that clear line of transparency builds trust and also brings everyone on board with projects they're interested in. Some patient partners may only want to be involved in short-term projects where they see immediate results. One of the key pieces with EMPaCT has been for every project that comes to EMPaCT, it must align with one of those 3 pathways. Is it research, policy, or practice? And then number 2, whoever interacts with EMPaCT should be part of a feedback loop so that they come back to the community offering what they've done with the feedback that they took in short and long-term goals. So I think that transparency and accountability loop will hopefully take away from the tokenistic involvement.
Great. Next question. Are there any initiatives or project EMPaCT has worked on to address anti-Indigenous or anti-Black racism?
We are looking forward to bring the projects that we're doing with EMPaCT together with the EMPaCT community to this forum. And I think I would really like to speak about those projects with the EMPaCT community here. If people can stay tuned for when we are next here, I would really like to bring them on that journey so we can share those perspectives together rather than Elise and I speaking of them. What do you think, Elise?
Yeah, I think so. And I think people need to be aware that we're still in our formative stage. So we are starting to do work, but we don't have a huge body of work to point to yet. And at some point, hopefully we will, and we will be able to speak more fully to those sorts of things.
Next question. In absence of having a patient partner lead the effort as a staff member from within the organization, how do we instill that desire for change among staff who currently oversee and manage patient partner initiatives and do not have that patient experience or point of view? How do we help them become enablers for patient initiatives?
Yeah, it's a really interesting question. I have colleagues who are researchers and who work on the patient engagement side who really believe very strongly that there needs to be training and awareness and support for the staff to bring them along. I hope that is something of an answer to your question. I'm not sure how much patient partners can do, because we're always the ones who are either invited in or not, right? So what we're trying to do with EMPaCT is create a model where people come to us. We're not invited into their tables, but they come to us. And then I guess the question is, you know, and we will discover this, whether they come to us and they're open enough to really work with us or not, or whether they need some training or not. We don't know that yet, and I think we'll find that out. I think in the classic patient engagement world, there are some really good efforts to orient and bring people along and so on and so forth. It's so I think I'll leave it at that. I don't really know. I'm hoping that answers your question.
I think for myself, all I can add is that doing this work on my own would have been impossible. It needed more heads to be able to see more perspectives and to really understand that journey, and all those perspectives needs more voices to be able to co-build the process. I couldn't have done any of this on my own from an institutional perspective or from an academia perspective, just because my knowledge is only part of the puzzle.
If I can just jump in, I think that's a really key point, because it is a partnership. So both partners need to understand each other and sort of come along for the ride, if you will.
So I think we have time for one last question, so we'll stop after this one. What are some strategies for ensuring that patients and members of the public engaged in research projects reflect the diversity of Canada?
I think that's really a grassroots effort. I think there is data which shows that our patient partnership models so far represent a very specific demographic, and that diverse tapestry is not being reflected in the patient engagement models that we have right now. So building more patient partnership models which are different, that engage more diverse voices, give them that space to be able to share without that inherent power dynamics. Building that inclusive space comes first, and then beginning to see how those inclusive spaces are being mapped across Canada. I think that perhaps is a way. What do you think, Elise? I think there's work to be done, certainly, in this space.
Yes, and I think there is some knowledge, or there's an acknowledgement, and there is funding and some prioritization through funding agencies like CIHR to see if they can do this. I think there's been some real efforts also to engage with First Nations communities, for instance, and build long-term relationships. I know a researcher who has been doing research with First Nations peoples for about 25 years, I think she said. And it took 5 years before they were open enough and they had built enough of a relationship for her to really do any substantive work there, as I recall her telling me. And so relationships take time. I think there is more and more recognition that it takes time. But the research cycles are such that, you know, that time is not baked in the way it needs to be. But I think that too is starting to change. If nothing else, COVID's pushed us to a more rapid research cycle. And that in itself, the fallout from that is, well, if you're going to engage people, then you need to actually have that building of those relationships almost outside any specific project. So you build the relationships and then draw on them when you have projects. And that's a more successful model, in my opinion. And it would be a more successful model for research. In some of the SPORE communities, they do have groups or community of patient partners who are interested in research, and they've built something of a community that way. So that's starting to happen. It takes a while. It takes a while.
It's almost as if we need it's almost as if we need a relationship grant.
Great, thank you. So we're just about to wrap up. Do either of you have any last thoughts or comments that you wanted to share with everybody before we end for today?
Well, I just want to say that it's been my very great privilege to work with Ambreen and to work with our community and the people who are supporting the community to develop this innovation, to see what works and what doesn't. And we need to just remember to be brave enough to cast out what doesn't, to be honest with ourselves and to move forward. But I'm optimistic. I'm optimistic. Yeah.
And I can say that I'm deeply encouraged by all the support from all the different stakeholders and deeply privileged to have this ongoing relationship with Elise and all the members of EMPaCT. And we look forward to, all coming here together, I think, at some point.
Great. Well, thank you both so much for joining us again. And we certainly look forward to the next presentation that you'll be doing with us and to continue to learning more about the excellent work that EMPaCT is doing. So thank you both so much for your time today. And thank you everybody for making the time and joining us for today's webinar. We still have more webinars scheduled for the rest of the year, so stay tuned. And if you've missed any of our previous webinars, they're all available on our website at survivornet.ca. So thank you everybody again and take care.
Bye now.